Okay, welcome to Medicine Grand Rounds. It's a pleasure to include all of you in this presentation. This is a special presentation that we have two speakers, Dr. Sam Monson and Dr. Danielle Loeb. Dr. Monson is a senior clinical instructor in the Department of Family Medicine, and she works at Denver Health in the Lowry Family Medicine Family Health Center. She received her bachelor's degree from CU Boulder in psychology, and then received a master's and doctorate in clinical psychology from the University of Denver. Her thesis focused on medical patient-provider communication in an area that she's become a specialist. She has been working as a clinical psychologist and health psychologist in the Lowry Family Health Center. Her focus, as I mentioned, is in patient-provider communication. She has also ventured into leadership development as well as burnout. Dr. Danielle Loeb is an associate professor of medicine in our Division of General Internal Medicine. She received her bachelor's degree from Cornell University and her medical degree from State University of New York, downstate. She also received an MPH, a Master's in Public Health, from the CU School of Public Health, and did her primary care residency here at the University of Colorado. Dr. Loeb's area of research has focused on primary care management of complex patients with psychiatric illnesses. And both of them are going to discuss trauma-informed care, what it is and why you need to practice it. Dr. Loeb will initiate the discussion, and then the discussion will go back and forth between Dr. Loeb and Dr. Monson. Welcome, Dr. Loeb.
Thank you so much, Dr. Schwartz. And it's an honor to present today, and an honor to present with actually Dr. Monson, who I've been working pretty closely with for the last 3 years. And I'll just say we worked closely on a different project than the one we'll be describing today, in which she did a lot of work one-on-one with providers in managing patients with mental illness. And so hopefully you'll benefit from her coaching today. All right, Sam, can you advance? We have no conflicts of interest to report. So today we're going to go on a little bit of a journey. The title is Trauma-Informed Care, what it is and why you need to practice it. But to get to trauma-informed care, you have to know a little something about trauma. And really, honestly, the first step of trauma-informed care is bringing an awareness of trauma and symptoms of trauma into as they show up in your medical practice, sort of into your care. So we're going to start with that, and then go into a more inclusive view of trauma, a broader view of trauma, and then some clear things you could do and apply to your regular practice. So we're going to do this in a way that we try to tell a little bit of a story of trauma, how it can show up for patients in actual patient care encounters, and even honestly for you as providers, because we're not immune. And we're going to intermix data from a survey that Sam and I did together with a team in primary care clinics at Denver Health. And then we'll offer some concrete steps of how you can lessen the impact of trauma in primary care. So now I'll turn it over to Sam.
Great. Hi, everyone. Thank you so much for being here. So let's start off with some basic definitions. What is trauma? SAMHSA describes trauma as events or circumstances experienced by an individual that are either physically or emotionally harmful or life-threatening. And the result is impaired functioning and or well-being. The CDC describes something that has been well established in the literature, a common source of trauma, which is known as adverse childhood experiences, or for short ACEs. This specifically points to traumatic events that occur during childhood in the 0 to 17-year range and fall into two buckets. The first being exposure to violence, either directly or as a witness, or the loss of a family member to suicide or a suicide attempt in the home. The second bucket is trauma via a maladaptive environment that undermines a sense of safety. This could be through substance misuse, mental health problems, or other environmental instability. So that is a pretty classic definition of trauma that I think comes into most people's minds when they think about trauma, childhood trauma, child abuse. Another classic source of trauma that people often think of is related to war or combat, active military or veteran status, for example, or individuals, civilians who are involved in areas where there is war or conflict. And another common source, often people think of sexual assault. And absolutely, these are all prominent sources of trauma. However, we now know, and the evidence is emerging, that there's a much more expansive definition of trauma. And that really, I think, is what makes the presentation at this time particularly relevant. One source of trauma certainly being individual experiences with racism, as well as systemic racism, Islamophobia and targeting based on religious status, food insecurity, housing insecurity, other stress factors associated with poverty, the collective, historic, and intergenerational trauma of Indigenous peoples based on the genocide that occurred on the very soil that we all now sit, and the long-term sequelae of that. Also, the ongoing negative policies and rhetoric for LGBTQ+ populations. And then current events, things like all the wildfires that went across Colorado this summer that threatened people's homes, livelihoods, sense of safety and security, and also health status as smoke expanded even beyond the borders of the fire itself. Also trauma based on people's experiences of medical diagnoses and disease and impact on functioning. And also the fact that trauma can also be had at the hands of a well-intentioned healthcare system. And finally, certainly the trauma that COVID has presented for this last year and continues to present both to patients, people in the community, as well as to those delivering care. There was a GIM town hall last night that presented some of the data from the recent American Medical Association survey on the impact of of COVID on physicians, APPs, and researchers. There were 800 responses in the School of Medicine. And this really points to the timeliness of paying attention to trauma. Here you see that there is a strong fear of exposure that survey respondents reported, fear of exposure to COVID. And again, that's consistent with that definition of an exposure to something that undermines your general sense of safety. Another pullout piece of data from the survey here, individuals reporting only approximately 15 to 20% of individuals reporting access to adequate resources to feel safe. So this is just underscoring the fact that COVID is a current and ongoing trauma that people are experiencing. And yet trauma exists on a spectrum. It's also dynamic and fluctuates with time and context. While we are seeing a dramatic rise in mental health incidence rates, this is in part due to the trauma that's being triggered in people right now by many of our current events. And if we think about trauma on a spectrum, in psychology, we often refer to little t trauma. These are perhaps the small or more micro events, which when added up can be much more significant. Also going out to full capital T trauma, which would be major significant events that acutely jeopardize life and well-being. We have two cases to illustrate this expansive definition of trauma. The first being Brody. Brody is a 22-year-old white transgender male. He comes into clinic for low back pain and is frustrated at a lack of improvement that he's experienced. You learn that he has been bullied as a kid for gender nonconformity, and that his family and community's Christian faith sent very strong messages from a very young age to deny any male gender identity. He was sexually assaulted as a teen, repeatedly misgendered by the healthcare system, and during his visits with you, he is intermittently reactive and aggressive, scrutinizes your treatment plan down to the very last detail, and is generally disorganized in articulating his needs. Here we have multiple trauma factors that we can pull out amidst the chaos of this visit and what may be experienced as quite a frustrating experience. We hear trauma of chronic pain, of a transgender identity, and the traumas associated with that identity being mishandled by the healthcare system repeatedly, the trauma of religious intolerance, and of sexual assault. Our next case is Kiera. Kiera is a 40-year-old Black woman in clinic for headaches and insomnia, also irritability, quote, irritability for no reason. Kiera has 2 school-age children and is married to, as she describes, a large Black man. And she says, you know what people think about large Black men. She works as a phlebotomist, and she's scared every time her husband leaves for work for his safety. She's struggling to balance her kids' remote learning, keeping her family safe, knowing that she herself has exposures in her job to COVID. Also continued excellence at her job, which is very important to her, and her own aspirations to return to school. In contrast to Brody, during the visits, she is incredibly calm and organized. Here we see trauma factors of racism, of COVID exposure as a healthcare provider, and COVID concerns as a mother. And the contrasting way that these 2 patients present shows that trauma appears in a medical encounter in very different ways. So who has trauma? I would say you should assume everyone until you know otherwise. Sort of kidding, but that is our theory. And that has certainly been my clinical experience in working at Denver Health. Trauma is far more common than not. Danielle's now going to talk about going back to that concept of the ACEs that the CDC puts forth.
So thank you so much for that, Sam. So ACEs, these childhood experiences, adverse childhood experiences. So this is data from a 1998 study from Kaiser, a large Kaiser patient population, in which they administered what's called the ACEs survey, which essentially just asks about the 10 ACEs, the 10 childhood experiences that were listed in that above definition. And you can see here that in that population, which I will state was mostly white, middle and upper class, college educated, and had primarily were employed. Even in that population, you see that about a little over a third of the patients had no history of adverse childhood events. The rest did have a history, and 4 or more is often a cutoff used for having very clear sequelae. And so about 12.5% were in that category. So what about other populations? So there has been actually limited research. Most of the research is from this behavioral risk factor surveillance system. It's basically a behavioral health survey they send out regularly, and one of them, there's 2 actually that found conflicting data on Hispanic populations. One found them at higher risk, and the other found them at actually at lower risk. It was Hispanic ethnicity being protective. What's very consistent is that lower socioeconomic status is a risk for ACEs, as well as usually, not all studies in these sort of secondary database studies, being Black or multiracial, and being gay, lesbian, bisexual, lower education, and lower income again. And then in terms of PTSD is sort of interesting. in the general population, so this would be a sequela of having a history of trauma, would be actually having a diagnosis of post-traumatic stress disorder. The lifetime incidence is 9.4. I have these references at the end of this presentation if folks want that, but that's generally what has been reported. About 10% lifetime incidence, about 4.2%. This is in the last 6 months. But primary care, usually the rates are much higher. I mean, they range from 2 to 44%, but most of them are much higher than the general population. So we, this is our research team, and I'll go into our study. So we sought to understand the burden of ACEs and lifetime trauma among ambulatory patients or primary care patients, actually, specifically in at Denver Health. So a safety net healthcare system. And, you know, particularly we were interested in primary care patients for the PTSD. And we also wanted to better understand patient preferences with respect to trauma-informed care. So what changes did they want to see in their care? So we did a cross-sectional survey at 3 different Denver Health clinics, primary care clinics. We used this pseudo-random sampling method that was based on appointment time. So we sampled from all providers in all clinic times and, you know, identified people by time. So it's a little bit convenient sample, but in a it's as rigorous as you can get in these kinds of studies. Eligible patients were adults in these clinics who spoke either English or Spanish. Should be noted, one of the clinics was Lowry Clinic, and that is a refugee clinic, but we only had a bilingual person administering the survey. So we did have a bilingual master's level mental health provider administering these surveys. Patients filled them out themselves, but she was able to explain the survey to people and to consent people, which we do think may have, which is quite different from these sort of secondary database populations. So our primary measures were the ACEs questionnaire. So that's just scored on 0 to 10, with each item being yes or no. And then we use the primary care PTSD screener. So it is only a screening measure, but there's one question pre-screening, which is asked about lifetime occurrence of trauma, which uses that definition, that SAMHSA definition that we saw at the beginning. And then if that's positive, they go through 5 symptoms of PTSD: nightmares, avoidance, vigilance, detachment, and guilt, and that's then scored on a 0 to 5. We also asked a series of questions about changes to the medical system that would make seeking care less stressful and preferred treatment pathways. It was primarily descriptive. We really were interested in incidence, prevalence of trauma in these clinics. And then we did do a multilinear regression to see if there was an association with these larger clinical risk groups. So it's a system Denver Health uses to categorize risk. Also mental health diagnoses, which we created a one variable of mental health diagnoses, as well as substance use disorders. So what did we find? We identified 786 patients, and then some patients either no-show, were never approached, essentially, because they either didn't show up or things were running late in the clinic. So in the end, 483 patients were actually approached, and we analyzed data from 302 patients. So that, I believe, was, we don't have it here, it was basically 63% 3%, with one being excluded recruitment. So who are these patients? So they're pretty different from the Kaiser study. They're predominantly female. Mean age was 44. They were primarily white, but you can see that large number of unknown other, and almost 17% Black. And then if you look down at ethnicity, about half the patients were of Hispanic ethnicity. So that's pretty different from that Kaiser study. Also largely Medicaid as insurance or Medicare. So this looks at our findings compared to something happened in translation. So we lost some of our percentages here. I'll give them to you. So look at the colors and you can see that 4 or more, which is often the cutoff for when you're really seeing the sequela, more sequela from adverse childhood conditions. And you can see that our population, that kind of teal color, is much bigger. So it was 40%. And the 3 was then, next down is 11%. So we found much higher rates of adverse childhood conditions than that Kaiser study found. And then in the PC-PTSD, so that was where we asked the first question of any history of a traumatic event. And that was extraordinarily high. 57% endorsed having had an experience of a traumatic event. And then of those, about half also had positive screening for active PTSD symptoms. So almost 30% of patients in this survey had over 3 current active symptoms. I will note, I'm sorry I didn't say it earlier, this was done in 2018. So this was not done during COVID or anything like that. This is before that. And then we also wanted to see, of those patients who screened positive for the PTSD, it doesn't mean they actually had PTSD. But they did screen positive, so they would certainly warrant more evaluation. Only 20% of them had any kind of trauma-related diagnosis in their charts. So that's of those 88 patients, only 20% had any kind of documentation or at least diagnosis of trauma in their charts. And so are these completely the same? Are ACEs, is everybody that has adverse childhood events going to have trauma? Does everybody with PTSD have an adverse childhood event? So no, there's a really strong overlap, as you can see. Close to all the patients with the positive ACEs over 4 with that higher cutoff did have PTSD, 55 of the 62. And then there were people with the positive PTSD screener that didn't have, I'm sorry, I just read that wrong. So 55 had both. And then there's 62 people that had had positive ACEs and no PTSD. And 36 people had the positive PTSD and no ACEs. So you can see that overlap there. So it overlaps, but it's not the same thing.
And I think that is really important to highlight that trauma does not equal someone being traumatized. There is a tremendous factor of resilience that determines what a patient's experience immediately is of trauma and then how that plays out over time. And there are a number of resilience factors that can play in. One that Dr. Loeb referenced, for example, appears to be Hispanic ethnicity. But there are a myriad of these that can mitigate the trauma from the later pathology being developed. But we do want to look at what is trauma diagnostically. What does the DSM say about trauma-related disorders? The category in the DSM is trauma and stressor-related disorders. There are a number that appear across the lifespan. They all look slightly different. Here you have the complete list, including, very importantly, as a psychologist, I will say, the other specified trauma and stressor-related disorder really gives the opportunity for us to continue to treat patients based on our assessment that the symptoms are trauma-based. as our evidence and science really catch up with this more expansive definition of trauma. But at the core, what all of these symptoms really have, diagnoses really have in common are three categories of symptoms. The first is some re-experiencing of the trauma. The second is that people try to avoid reminders of the trauma or triggers of the trauma. The third being a hypervigilance, or constantly being on guard for the possibility that that trauma may be returning, that safety may in fact not be experienced. And so now we shift to looking, how does trauma look and feel in a medical encounter? So based on the data that Dr. Loeb presented, it is not always known that a patient has trauma, and yet many of the behaviors that we experience from patients may in fact be trauma related. So for example, the category of re-experiencing the trauma. We may see that in a patient as having elevated blood pressure, appearing really agitated during a visit, very irritable, and potentially quite scattered or disorganized and chaotic. These are the patient visits where it's hard to even figure out what you're addressing before the next thing to be addressed appears to be being raised. In the category of avoidance-based symptoms, we see patients missing appointments or just completely missing key aspects of their care plan. Potential non-adherence to a care plan because of the way that their trauma symptoms are playing out for them. And lastly, in the category of hypervigilant symptoms, we see patients providing, for example, very excessive detail during an assessment. These are patients where it's hard for them to sort of contain the amount of the information they're giving because they're so concerned that if they don't give every last detail, they may not be understood and they may therefore not be safe. And it may ultimately still lead to them questioning a plan because, again, they're concerned that a miss or a detail or something gone wrong will equal lack of safety. So all of these behaviors, I think it's important to recognize, while they can be frustrating in the moment, it's really a patient trying to cope with the changes that their brain has experienced based on trauma. They really are doing their best here. So why shouldn't we ignore trauma, despite the fact, in addition to the fact that it comes up in visits, whether or not we invite it in? One big piece is because it is correlated with chronic disease. This is a common graphic that represents how those adverse childhood experiences, which you see at the bottom in the pink band, cascade up throughout the lifespan to ultimately create earlier death, which we do see as many as decades earlier of death based on trauma exposure. So you can see we have from ACEs, we go to disrupted neurodevelopment, social, emotional, and cognitive impairment, which can lead to the adoption of high-risk behaviors, which leads to increased rates of disease, disability, and social problems, and ultimately earlier death. So our results as it pertains to this, what I'm showing you here is the multivariable analysis that we did that showed that separately mental illness and substance use disorders each had an association with the cutoff of ACEs greater than 4. And again, as Dr. Loeb said, that's a common cut score that's used in the literature. Also, when we reran it, there was a linear relationship with ACEs. So that means that as ACEs go up, as do mental health and substance use disorders. The CRGs that Dr. Loeb described earlier, basically a way to capture medical risk. Though those were not shown to have an association, we did not look at individual medical illnesses, which is what other studies have done in the past. And so we are going to be going back to look at that specifically. So why else shouldn't trauma be ignored? Well, very importantly, if we don't know about it, then we can't offer patients treatment. So if there are things, for example, any of the behaviors I described before playing out in an experience that you're having with a patient, and you consider that trauma might be present and ultimately that's identified, then patients can get treatments. We have really robust data and good treatments for patients to be able to have these symptoms that are not only coming up in medical visits, but in every aspect of their life treated. So there's really robust data for the use of prolonged exposure and cognitive processing therapies, as well as trauma-focused cognitive behavioral therapy, or CBT. There's also emerging data for other therapies, such as EMDR. And I really think in the medical setting, the need for treatment can be likened to, of course, we check blood pressure because we have good treatment for hypertension, and we know that it can really impact other parts of health and well-being. Same thing, we want to be having trauma in as part of the conceptualization of what we can treat and help patients with. And here we have a sort of a shift. So we also wanted to really have, as part of this conversation today, the fact that providers, medical providers, are humans and are not immune to trauma. And going back to the GIM data that was presented during the town hall last night, we see this very clearly, that providers absolutely are also experiencing trauma. So providers can experience it just based on their own personal histories or individual experiences. Maybe the providers are part of a historical or collective trauma experience, for example, that intergenerational trauma for Native providers. Also, there is unavoidable exposure to trauma through patient care. And this can look like a number of different things. It can include experiencing and witnessing patients suffering and dying. It can include hearing and being exposed to patients' own trauma stories. It can also be the experience of the inevitable errors that will occur or unanticipated outcomes of medical treatment that in themselves feel like a trauma to providers. And so this is really where the concept of countertransference and transference comes up. These are psychoanalytic principles that were originally proposed in the early 1900s, but have increasingly been expanded to any helping profession. Transference being the feelings of a patient as a human toward the provider as a human. Countertransference being the feelings as a human of a provider toward a patient. And so what we see is that if we ignore the fact that providers, that we ourselves can have trauma, we ignore the fact that this comes into play in our helping relationships and will play out whether or not we want it to, unless we recognize it and work to manage it. And we're humans. So here you have everything that includes the orbit of the patient, everything that includes the orbit of the provider. As humans coming together, there's going to be a unique dynamic. And so what we see is that providers who have their own trauma experiences, again, on a spectrum from little t trauma to capital T trauma, fluctuating over the lifespan. As patients come into your care, you may experience different patients very differently. There are certain patients who will be very upsetting or stressful for you that other colleagues may say, that doesn't really get under my skin. That's exactly what we're referring to here with one way that trauma can get stirred up in a provider as a human and can end up playing out in the care of a patient. And this is not because anyone is doing anything wrong. This is because people are human. So vicarious traumatization, the definition here is that it can be understood as related to both the graphic and painful material trauma clients often present and to the provider's unique cognitive schemas or beliefs, expectations, and assumption about self and others. So here exactly when you have heard of vicarious traumatization or secondary trauma, this is really the intersection of those two pieces. The patient's experiences and how that mixes in with the chemistry of your own experiences, what reaction occurs. COVID is an excellent example of this and presents ongoing traumas, as does systemic racism. These are things that providers and patients are both steeped in at the same time and may come up in different ways in different patient encounters. It's also really important to note that trauma in itself, when recognized, understood, and appreciated, can really be a superpower. There is a centaur in Greek mythology, Chiron, who was accidentally wounded and after being wounded was in chronic, severe pain and was incurable and was renowned as a teacher and a healer. And this really has brought forth the concept of wounded healers. And when we recognize that we are not immune to the effects of trauma, we can also realize that that very trauma and the shared emotional experience with a patient can provide a unique and deep empathy, which in itself can enhance your patient care. So the idea of trying to push trauma away or say, we as providers are not going to think about a trauma in relation to ourselves, we're going to just have a think about it in relation to patients, really robs us of the opportunity to say, how might becoming empowered over our own trauma survivorship help us uniquely connect with our patients? And yet here we find that despite all these reasons that it shouldn't be ignored, trauma is often absent from medical care. Just to review here, these are the data that Dr. Loeb presented before. I want to underscore again the fact that a third of the patients in our ambulatory care, primary care population had active PTSD symptoms. 3 or more of these active PTSD symptoms. That is tremendous. That's a third of patients walking through the door. That is not mental health patients. That's everyone walking in for every reason. And then of those patients, the vast majority, nearly 80%, had nothing in their chart about trauma. And this is really not at all a deficit of the providers providing care. This is absolutely a failing of our system. And it fails both patients and providers because our system simply doesn't allow for all of the things that need to be included in a medical encounter to always be included. And here I'm preaching to the choir. You know, there is far more to be covered than you can ever reasonably cover in the amount of time that you have allocated for a patient. And so I think this points to a systemic problem that while we know that trauma is omnipresent, that it is meaningful, that it is significant, and we have treatments, it is often left out. So what do we want patients, what do patients want us to do? What do they want us to do with all of this information about trauma? Dr. Loeb is going to share what our survey found regarding this.
So yeah, can you pull up the trauma-informed care? Yeah. So my personal opinion, and I'm not alone, is I am a primary care provider with all those millions of things to cover. I do ask my patients about trauma, but I don't even necessarily always document it as a diagnosis, especially if it's a history of trauma, but not clear PTSD. So what do you do in that case? What does the system do? So the answer has been this notion of trauma-informed care. And yesterday, actually, at GIM Grand Rounds, Dr. Connors introduced, I love the way he phrased this. He said, now we are entering a evidence light zone. And that would be the case with trauma-informed care. It is a evidence light zone. There's not a lot. But the concept, the way I like to think about it is kind of like universal HIV precautions. As somebody, who trained as that was instituted, or a little after, but still, assume patients have trauma as individual providers and as a system. So trauma-informed care does that. So it's a framework that is, it's responsive to the needs of patients with a trauma history. So it can be applied on a patient by patient basis, but it can also be this sort of universal precautions where the whole system, you as a provider are gonna ask permission before you touch a patient to listen to their heart, things like that, and just develop it as a regular part. So I will say these have been minimally studied, really rarely studied. Education of providers so far has been the only thing that has shown a lot of evidence in changing practice, changing patient satisfaction. But this is a new field, I would say. And so what is universal trauma-informed care? So this is SAMHSA's definition here. And this is actually of an organization that provides trauma-informed care. So I would hope this is what all of our organizations are striving towards. So it's sort of realizing that widespread impact of trauma is present in our patients, recognizing signs and symptoms across the institution, and responding by fully integrating this into policies, procedures, practices. So then back to our study. So what did we find? So patients, we did ask how stressed people were. These are the questions we wrote. So does going to the doctor make you feel stressed? And you'll just note that the very stressed or extremely stressed were not that high, but you can see that the people with a history of trauma, which was defined as an ACEs greater than 4 or a positive PC-PTSD, which is a greater than 3 or greater, 22 of those versus only 1 of the people without the trauma history. And then somewhat stressed, you see that as well, higher numbers in the people with the trauma history. And that was statistically significant. And so we went on to ask, I mean, I'm not giving you all these results because it was a lot of questions, but the big take home for this, and we're running close on time, is just notice that this is, these were questions, what would it be helpful, or would it help you feel less stressed if these things happened? So all these questions are about the front desk, or sort of things that happen before the visit, things in the environment, the healthcare environment. And I honestly thought these would be higher, to tell you the truth. You can see the blues are the whole sample, and the reds are those with a history of trauma that met that threshold. So you can see that people did feel like these things would help them, to have the phone staff take more time and the front office staff be more respectful. That was the highest in these. So these things definitely matter, but then go to the next slide. This is you, or these are providers. So you just look at the general height of these. People, it's, you know, the visit with the provider is the most intimate part of the visit. And also the most, you know, it's intimate. It's also vulnerable in terms of like, this is where their care is happening. This is who's going to decide, you know, what happens. So all the things, you know, you can just see it's pretty dramatic. Like if your doctor was the same every time, was quite high, this consistency. So that's sort of a system level thing. But then if you look down to the second to last one, your doctor explained what was happening during the visit, during the physical exam. That's really important. It's really easy to institute. You know, I'm going to listen to your heart now. Is that okay? Your doctor asks your permission before doing the physical exam. So these are things that are pretty, you could do this, you know, we could do this.
And so as we conclude today, we really want you to recognize the piece of trauma-informed care that we're suggesting you bite off is not trying to change the system and not trying to add things to your visit, but really to have you increase your awareness and recognition of the prevalence of trauma in patients and in ourselves, and the way that that plays out. What is within our locus of control as providers is our own behavior and our own choice to engage in self-reflection. And so that is really what we were hoping to insert in your brain today. And if that is the one and only thing that shifts, that is in itself a significant shift toward trauma-informed care. You know, medicine really has a hidden curriculum to ignore personal experiences and instead focus on the patient. We're asking you to fight that, to look inward. Here we have Carl Jung reminding, your vision will become clear only when you can look into your own heart. Who looks outside dreams, who looks inside awakes. What do you need to understand about yourself, and what do you need to take that trauma and engage it as that wounded healer opportunity to connect empathically with your patients? Also, assume that a patient has trauma unless proven otherwise. These are only a few of the examples we've gone over of sources of trauma. The definition of trauma is ever expanding, and our understanding that all of these definitions change the brain to be wired differently makes it key and central to the fact that you hold this in mind for every patient who you see, especially the patients who challenge you, who you really need to figure out ways to connect with. It can truly shift your thinking about those patients. That instead of asking or wondering to yourself, what is wrong with this patient? Instead, you think, what has happened to this patient? What has been done to this person? To help you really find your empathy and connect with that patient. And so overall, don't forget about the resilience that trauma can offer. Like we said earlier, trauma does not mean traumatized. Even if traumatization is temporary, it does not have to be forever. We have excellent treatments for it. Patient and providers alike can benefit from these. And ultimately, it can be harnessed to become a superpower of connecting with patients, which in itself is healing. Thank you so much. We did have a couple of questions that we thought we could pose, but there may be other questions that were presented in the chat. We'll now open it up. Dr. Schwartz, thank you so much.
Okay, well, thanks very much. That was a really great talk, and I think this topic is definitely not discussed enough, especially given what providers are going through and what the folks in our community are going through at this point in time. It's no one would have guessed in their wildest imagination that we'd be at this point in November of 2020. So let me start off the questions by asking you a little bit about resilience. Resilience is an odd topic, but it is really clear that not everyone, in fact, less than 50% with childhood trauma go on to have PTSD. So what are the factors that distinguish those who go on to have PTSD from those who don't? And how can we work with our colleagues in pediatrics to help embed resilience in these individuals that are undergoing or are subject to childhood trauma?
Sam, I'll defer to you on that, and also note that Dr. Flores asked about why Hispanic ethnicity might be a protective factor. Maybe you could address both.
Absolutely. I'm so glad that we're starting off with resilience, because to talk about trauma without talking about resilience would really be a disservice. Resilience is a really complicated question, a complicated construct that we're still trying to sort out. But I think the easiest way to get your head around it quickly is to think about Maslow's hierarchy of needs. And if you have a trauma that occurs in the absence of basic needs being met, it's going to be harder for the brain to incorporate that trauma. And so if there are things that can be done to structure up a patient's basic needs being met by pediatric colleagues, for example, that is going to be tremendously helpful in those trauma experiences being folded into the brain in a way that does not create pathology later. A specific example would be connected when we can work with social work colleagues to connect patients to make sure that there is adequate food in the home, that electricity is turned on, so that those basic needs are being met. Another big trauma resilience piece that I think relates to the fact that Hispanic ethnicity has been found to be protective is social connectedness, and specifically a sense of safety, security, and stability in social relationships. And we see the collectivistic, community-based sense of self in Hispanic cultures, and the fact that that is so prominent culturally for patients is one theory why that may in fact be protective. When we experience a trauma in isolation, it is much more significant and lasting than a trauma when we feel that we are a part of a network of other humans from whom we can draw strength.
Yeah, I'll just pipe in terms of, I'm in the transgender clinic. I provide care in the transgender clinic, and we do a lot. I always try to talk to patients about how connected they are with the community, tapping into community resources. And that seems to play just a huge role in terms of how patients are responding to past traumas or current traumas they may be experiencing, microaggressions they're experiencing, how connected they are with their community. Just almost impossible to say how much that matters.
So how has that been affected by social isolation related to COVID?
That's so important, Dr. Schwartz. Early on, Jacob McWilliams, who was running the gender lab down in office down at CU Denver, was saying that he was getting patients, especially patients who were either lesbian, gay, or transgender that were not accepted by their families, having to go home to their families was actually when the campus was closed down was, I mean, people were, I mean, suicidal essentially, you know, in their office over that. And then just the lot. And so there's that big T trauma over that kind of thing where they're really isolated versus patients that, or people that are just not able to connect. And I've been like trying to get people to connect on Zoom for things that they're a little resistant, but there is a lot. I mean, I think various communities are trying to reach out on Zoom.
Mm-hmm.
And I think that it's such a good point that right now the physical distancing, and I'll try to use that term deliberately instead of social distancing, is presenting unique challenge. And I think if we pull the cognitive behavioral therapy principle of all or nothing thinking and try to use it to challenge ourselves and talk with patients, yes, it's harder to feel connected. Yes, it's harder when we're talking about distance, but it doesn't have to be a nothing then. And so what are the things that you can put into place that will still help you feel some degree of connection, recognizing that it may not fulfill that whole need? Which is uniquely important because, again, COVID in itself is a trauma. And so we want people to still be trying to engage in that connectivity, to be buffering against the active trauma that we as a society are experiencing. This may be talking about their engagement in healthy types of social media behaviors, connecting virtually, or connecting in ways that current public health guidelines allow, for example, outside distance with masks at times that is allowed. And to really create flexibility for patients about the fact that these things will shift over time, but that relationships can still endure.
That's great. So let's talk a little bit about the provider-patient relationship. What do you do when the patient denies, admits to or discusses childhood trauma, but denies the relationship between childhood trauma and the problems that or the conditions that they're coming to you complaining of? And this questioner was particularly interested in patients with heavy somatization.
Do you want me to take a stab at that, Danielle?
Sure, and I'll piggyback.
Okay.
This is, I will say, the kind of thing that, the kind of coaching, I think, having I will speak up first and say, if you have a health psychologist, a clinical social worker, somebody like that in your clinic, this is where they can be extremely useful. And I think Sam has done a lot of coaching of providers around this, and then I'll turn this over to you.
I think this is where patient-centeredness really has to take priority. If you jump to trauma and a patient, you have to remember that one of the key symptoms of trauma is avoidance. And so the brain tries to distance itself from trauma as much as possible. So it is not at all uncommon for patients to have ongoing physical symptoms or a physical manifestation of their distress, for example, often called somatizing. Though that is because that patient is engaging in that avoidance. You have to remain patient-centered and close to their experience, or you will just completely leave them feeling misunderstood and invalidated. And so the place to really start is to lean into the pain and to lean into the symptoms, and then to get them to understand that you are there for them, to create that sense of safety, that you're going to be there to help figure this out, that you understand the depth of the impact on their life, and that you want to get to know them as a person, including these other pieces. And as you create that safety, that relationship, that rapport, during a particular visit or across multiple visits, you may be able to start asking the patient about things in their life that have been challenging or hard for them, and share the fact that we know that people who have been through challenging or difficult things in the past, often that is hard for the brain to incorporate. And so it comes out as physical symptoms because it's so challenging. And having those kind of gradual conversations that shift toward that as the etiology can ultimately help the patient make a connection, but it takes a lot of patience.
Yeah, and I think how that works for me, in my language is one thing I try to do is like I was saying, a lot of affirmation of like, I'm so sorry you're hurting so much, and or whatever the physical symptom is, really sit with that with them. And it doesn't mean I have to sit with them for an hour. Do you know what I mean? I can do that pretty effectively, pretty quick, and by repeating using their own words, repeating their own words, and kind of being with that, because a lot of folks have never had somebody be with it, you know, and I will say, you know, and if I think there is something physical, I mean, often there's some inner action, right? And I will say, okay, for the physical, or I won't separate it, but I'll just recognize, yes, I get that your headaches are terrible, or your insomnia is terrible, or your musculoskeletal symptoms are terrible. And it can sometimes really help those to start to address some of the psychological aspects of these symptoms. Or so it's a sort of yes and rather than no but. You know what I'm saying? Like, it's like, you know, like I always try to word it as an and. Like, let's look at both of these, or and it was just amazing to me when I started just to sit back and provide a tiny bit of space for patients to express their sort of suffering around whatever it is that these physical symptoms are, without trying to fix it. Because I felt so compelled to like have an answer, and just to often I have found that it is quite therapeutic for patients to have somebody with an MD after their name just listen to them for a minute and not discount their experience. So if I can find any way to sort of do it as an and, or do it as an also, and also just really hearing them. And again, it doesn't have to take 100 years, you know, it doesn't have to take all your visit. It can be done pretty quickly.
That's great. It seems that only 40% from the data you presented, less than half of the patients find it valuable to talk about trauma. I guess the question is, what are the things we shouldn't discuss in that interaction? What are the issues that would maybe even cause more problems for those patients that have experienced trauma and really don't want to talk about it?
I mean, for me, and then I'll leave it, I'll turn it to Sam for that. It's a listening, it is that patient-centered listening. I don't think there's a rule book for this. It has to do with, sometimes patients will volunteer it and they want to share it with you. Other times I'll ask and they'll say, yes, but I don't think it has anything to do with this, you know, or you'll sense a hesitation in talking about it. I think the key for me is approach kind of like Sam was just referring to, of like listening, taking little steps with them, because in a 20-minute visit, I'm not their therapist, and I'm not going to be able to kind of put them back together, right? So it's sort of, if they want to share it, letting them know I'm there and I will hear it, you know, and I care. But I never push along those lines, I guess. So maybe that's the rule, is not to push. Sam, do you have a clearer way of saying that?
No, I absolutely, I agree not to push. And the way I sort of think about it is, if you're going to make an invitation for the patient to share a part of their trauma narrative, you want to couple that very closely with empowering them to decline. Because we know that avoidance is a key symptom, and frankly, that effective defense mechanisms closely tied to resilience sort of create a cordoning off of the trauma. If you poke at that too hard, it may come flooding out, and it can be really overwhelming for the patient. And patients experience this, whether consciously or unconsciously, and so they are protective of themselves. And so to invite them to be protective if necessary. So something like, I'm curious about experiences that you may have had in the past where you really didn't feel safe, or you felt like your life was in jeopardy. I'm going to ask you about that, but I also want you to let me know if this is not a space that you're ready to share that, you are in charge and you do not have to.
That's good. That's good. Great. So I want to end with one question that moves to the provider. And I really like the slide that Dr. Monson had showing the interaction between the provider and the patient and the psychology that both bring to that interaction. And the question really relates to how can we create resilience among the provider, not to develop burnout in relation to the empathy and the empathic approach we're taking to the problems that the patients are bringing into that situation.
I think the first step is being kind to yourself and allowing yourself to own trauma experience that you may have had. And then to start to understand what you might need in order to start to tighten the fabric that you have around that to create more of a network of resilience. And this can range from self-care to setting boundaries in the way that you take care of patients to actually getting your own trauma treatment. But the first thing is to really look and say, is trauma a part of my story? And if so, what can I do to help myself be more resilient? And how can I ask my community or my system to support me in that?
Mm-hmm.
Sam, can you address at all, like something that we might not consider trauma per se, but I think feeds into this, which is, say a patient reminds me of my father. And so I find myself being reactive in the visit. Like I find myself getting kind of hot or, internally, or just feeling like, oh, I just kind of snapped. And I don't snap at patients, and it's not that there's a particular trauma, but it's bringing up something in me. Do you have anything around that?
Absolutely. These are the heart sync patients. And these are different for every provider. So these are the patients who you see them on your schedule and you go, oh no, or perhaps particular diagnoses or parts of a problem list that you think, oh gosh, this is going to be a tough visit for me. That's where you really need to increase that self-awareness by checking in with yourself during or after the visit. Is my heart rate up? Am I sweating more? Is my rate of speech getting faster? All of those are signs that this patient is stirring something up in you. And if you can start to notice what that is and start to notice patterns, it may help you realize what are the pieces of your own experience do you need to spend some time on.
Mm-hmm. Great. Well, this has been a terrific discussion. Really learned a lot from both of you. Dr. Loeb, Dr. Monson, thanks very much.
Thank you. Thanks, everyone.
Thanks, everyone.